Most of you may know Karen Desalvo. I knew her when she was the health commissioner for the city of New Orleans with Mitch Landrieu, and before that was his chief health advisor. Is now, and will soon be, because she will be confirmed with unanimous consent, the Assistant Secretary of Health and Human Services for Health, which means you do everything except for human services, which is fine. So, and she's a very good person, too. So thanks for being here.
Oh, thank you for having me. I'm really excited to share a story.
Well, as usual, especially since we have some New Orleans people here, and Kathy and I are just trying to get a one-bedroom little apartment on Royal and Dumaine. So we're going to geek out on New Orleans tonight, which is, tell me, first of all, how was health in New Orleans before the storm, the big charity way of doing things, charity hospital?
You know, earlier today, Louis Sullivan was talking about how in some parts of the U.S., health statistics are like they are in developing countries. And New Orleans is one of those places. Louisiana was consistently either 49th or 50th in health in the country. And New Orleans itself was usually the most, or one of the most unhealthy parishes, as we call them, or counties in the state. And that was a mix of things. It was about, lack of access to care. It was about lack of health insurance coverage. It was about health behaviors. It was about infrastructure that didn't offer healthy foods or green space. And it was really also about all those other indicators of health, poverty and public safety. And so when you looked at the challenges that city was facing generation after generation, and we were really honestly set up for failure, because we had a population that was very low resource, high burden of chronic disease, a high burden of acute disease like asthma, who was, because of our funding system and because of the way we had built the bricks and mortar, dependent on emergency rooms and essentially dependent, thank you, on a central public hospital system. Since about a third of the core of the city of New Orleans was uninsured at the time of Katrina. So it was very centralized. It was pretty broken and not really getting the kind of.
It was sort of a Huey Long legacy, because he built Big Charity Hospital, and he did it for good and noble reasons, but it sort of centralized everything is the problem, right?
Right. The way we funded healthcare in Louisiana was that we used a sort of a block grant program called Disproportionate Share that put money into the public hospital system that was run by the state. And the type of money that was, this DISH money, meant that it could be largely only used for health services in a hospital and not community-based or primary care. So when that effort started to happen in other parts of the country of neighborhood-based care, we got really far behind and further behind, and made fewer and fewer primary care physicians and mental health providers and others. So, a really noble idea of an institution that trained me and pretty much everybody I know that's a doctor in Louisiana and a nurse. My aunt's a nurse, she trained there. My uncle's a social worker, he trained there. Charity Hospital. Charity Hospital. So, really all in our hearts, but more of an old model of care that was just not really meeting the needs of the population.
And if you were to design a healthcare system from scratch, if you could just say, okay, in this city or in this state, leave aside the Affordable Care Act or single payer or whatever, how would you design a healthcare system?
I think that's a softball question, because that's exactly what we had the chance to do after Katrina. And look, I want to be respectful. So for those of you that are not tracking on this is our 10th anniversary. So it's a big year of reflection for all of us from the city. We're spending a lot of time thinking about what we've done. But let's not forget that Hurricane Katrina was a devastating storm that took the lives of about 1,800 people. And in our community, New Orleans flooded about 250,000 structures. In some parts, like Chalmette, every single facility, building, house, whatever, was flooded. And it just took down everything we knew as institutions, including healthcare. So from 911 all the way to our academic health centers, like Charity Hospital, where Tulane and LSU trained, were shut down, with some very few exceptions. And so as we literally stood on the street with water around and guys with machine guns and thought about how we were going to meet the urgent need of today, we began thinking really quickly about how we would build something better. So how from scratch could we build a healthcare system, given that everything was down and we wanted to put it back together again? And I'll tell you, Walter, we did not want to put it back together again the way it was, because that was getting us this set of outcomes that were so poor, and driving people to emergency rooms and picking them up after they had fallen, treating diabetes in the ICU and not preventing it. So we could certainly talk more about the process, because I think that's really the success story of our city, but through a really heavily civically engaged movement, very grassroots, we built a framework, and that framework said we're going to pay for care differently. We're going to, first of all, make sure that everyone's got coverage so that they have a voice and a vote and they can choose their care. We want to make sure we're rewarding value and primary care. Secondly, we wanted to build a base of primary care where we hadn't had any, and not rely on hospitals, the most expensive place, but build a foundation of primary care. Third, we wanted to enable that with health information technology. So we would have the data necessary, the information necessary to take care of people and populations, and do that in a way that was continuously getting better. And finally, we wanted to set some goals around quality. So what is the quality table that we would set? And how would we figure out the most complex and terrible things that were scourging our community and tackle them one by one. And so we set out to fulfill that policy agenda, which was really created by a broad cross-section of people across the state with help from the federal government at various times, and it's been largely achieved, except for the financing piece. We have gone from having essentially no neighborhood-based care to having now a set of 24 different organizations that work cooperatively at about 60 sites across the city, deliver primary care, mental health, work with the hospitals, are all IT enabled, sharing data, focusing on quality, and the indices are all improving year over year over year of
Yeah, I
better
saw
care.
a journal piece you read, I can't remember the name of the journal, but it had the map of where all these places were too. Did that spring up in a neighborhood way, or did you sit and look at the city and say, here's what we're gonna do and how we're gonna make it work?
We were, so, you know, we did not, we were not that deliberate.
Right.
And the reason I'm shaking my head is because there was literally water in the city, and we were under martial law. And what we were trying to do initially was just meet the needs of people on the street. So though most of the city evacuated, there were still tens of thousands of the sickest of the sick and the poorest of the poor left in the community. They had not evacuated. A lot of the first responders, pretty unhealthy, people who came to help. So there was immediate need, and what emerged was this rush out to help, where we set up urgent care stations, basically ice chests and card tables on the street, and started to deliver care, whatever was needed. But some of those sites on the streets became permanent. So we, for example, broke into a boys' dorm at Covenant House, which is a place for young people who are homeless or have other challenges. They had all evacuated. It was across the street from the police station. The cops did help us. We broke in. We had a shelter then, a place to store stuff overnight. That grew into a clinic, which now is its own building, but is a top-tier accredited medical home, like top-tier primary care and mental health services, teaching new health professionals, doing research. So it was like that. It was as though we planted little seeds right after the storm in the weeks afterwards to meet urgent need on the street, and some of those grew into permanent sites in churches, in stores. I mean, there's sort of countless ways that happened. And what makes that so special is it wasn't like we just looked at a map of the city and as a policy group and said, this is what should happen. It was on the street where people were to meet their needs with them and build the healthcare with them iteratively over time. We did do the policy framework in the back, right? We wanted to make sure that we got it right, and we used evidence to design, but we didn't want to do it separate from community. We did it with community.
Yeah, you know, that's one of the themes of the whole resurgence after Katrina, is that whether it was education, neighborhood and housing, or healthcare, we started off and had it pushed on us that we should have comprehensive plan, and then it all grew from the neighborhoods up. And that, in some ways, that made it better.
Yeah, the story of the rebirth of our city, there's lots of ways to tell it, but for me, it's about a place that was left for dead and decided it didn't want to be dead, that it looked around and where we found friends or each other, we held hands, we stood up off our knees, and we moved forward, and we said we could do better by the people of this city. We deserve a better community that has better education, better criminal justice, and did it together. And in healthcare, I have to say, though we did do a lot of community planning and at times government was involved, a lot of what grew in our community health work and other efforts that happened beyond, like in public health, really started outside of government. We did it in a very civically engaged fashion and decided what was right for the people of our city and moved forward.
Yeah, it was sort of like each neighborhood grew up. And it was partly because government, with some exception, was kind of a mess. I mean, we can say this now.
You're very
Mayor
kind.
Nagin was not the strongest leader. And even Kathleen Blanco, the governor, decent person, but just didn't come in there and figure it out. And FEMA was an absolute disaster. And the federal government, except for Mike Leavitt, who you worked with, who was the Secretary of Health and Human Services, very good, there was just no government to figure it out.
Yeah.
And maybe that was a silver lining, as there were many silver linings in this storm.
Yeah, government in many ways did fail, especially in the beginning, because it was overwhelmed, just like the levees, right? It just was too much. And it's so hard to explain to folks who weren't there what that feels like when everything that you know for certain, every institution, every hierarchy, every set of communication, everyone who works for you, when it's all gone. So it's no wonder that happened, especially to a smaller city government. And I think what a lot of us expected is that there would be layers of government stepping in, and it just didn't happen right away. But as you say, I think over time, our governments got back on their knees, but absolutely Secretary Leavitt and his team, he really got it quickly that there needed to be a structured framework. The U.S. Public Health Service came in very early, really put structure on the ground to give us sort of a true north. It's going to be okay. You're going to go this way. We're going to help you, down to giving us internet access and taking notes at meetings, just ways that they helped to continue to propel us so we didn't go backwards, which is not what we wanted.
In order to not make this seem like a total cheerleading session, though, if you talk to Mike Leavitt now, he will say that there were some still enduring failures, that getting LSU and Tulane to work together still hasn't happened, that the hospital system being built is probably not calibrated correctly. And he has some real frustrations. I mean, where were the failures that you see? And you know what Mike Leavitt has been saying. So, what do you think of that?
Well, so the financing piece is where, look, we could all agree that everyone should have access to great care that was patient-centered. It's what grew naturally in the wild. It was team-based care with mental health. That was a really easy place of agreement. We moved forward on that. Quality, pretty easy to agree on. Health IT, yes. But the money was hard, and we should have thought about that harder, faster. It's about $1 billion of disproportionate share money in a tiny state, the population of only about 4.3 million, and we had more dish in New Orleans than all of Florida did. So it was a lot more disproportionate share money.
Yeah,
this block grant funding
the
charity hospital in New Orleans than the entire state of Florida had. Right. Like, we were really good at that game of getting that money. Shalea's going to tell us all about it.
Yeah.
And so we were using that money really well, but what we wanted to do, what Leavitt wanted to do, and a lot of us in the community, was to use that money to help people purchase health insurance so they wouldn't be bound to a system, and that we were never able to work that out. What we did work out, outside of the government, frankly, the community came together and worked out a plan to provide a temporary waiver. It's called 1115. It's a special way to provide coverage just for primary care. We're still living under that. There's about 56,000 people in our community still getting care through that financing system. But before I forget, while I'm on numbers, you should know that it's about 10% of the New Orleans population, greater New Orleans population, is getting care in these neighborhood-based clinics now, which is about the same population that was going to the ERs at Charity before. And when we do the cross-mapping of the people, we have been able to pull people out of the ER. The ER visits have definitely gone down. Now, where we haven't made as much inroads yet is in young populations, like teens. We're still seeing major challenges with health around sexually transmitted disease, around teen pregnancy. So, though we've been able to touch chronic disease populations, we're still struggling with some of the everyday social and other challenges that the community's facing. So I'd say financing, touching all the populations really well are two areas where we still haven't gotten ahead. And I think the building of the hospital, Walter, it's a story still unfolding. We were just talking about it at the table. So Charity was closed, and that building never reopened, that big old 1930s building. But on the other hand, it's been operating in a smaller facility. Now this new $1.2 billion facility is open. At least that's the last price tag I saw. And it's magnificent. I mean, it is a spectacular building that's going to attract doctors, nurses, medical students, researchers, I think from certainly all this hemisphere. And so I think the rest of that story about the tertiary quaternary system is left to be written. But the primary care piece is pretty wildly.
Well, let's talk about it. It's a university medical center, and then Veterans Hospital, and then the big old hospital that's now taking it over. Do you think that there's an incentive to overbuild? Because it's magnificent, but it may be something that was done simply because it could be done instead of needed to be done?
Yeah, so if you'll allow me, there's two parts to the story. First of all, if anyone heard Eric this morning, he was talking about getting health care, how healthcare in maybe not the not too distant future isn't going to require so much bricks and mortar, basically, so much that we can do
beds, yeah.
asynchronous and beds. So as even 10 years ago, as we were asking this question in our planning efforts, we pretty resoundingly said as a community we should not build back beds. We should build fewer beds. And in some cases we did do that. The VA scaled way back. New Orleans East, we scaled way back. But and even really at the University Medical Center, there are technically fewer beds. But we were still on a trajectory to build a healthcare system that was pretty hospital focused. And that would be another place I bet Levitt would say we didn't take the chance to really jump ahead and think about what's going to come into the future in terms of pure healthcare. But what that University Medical Center does do is it's a biomedical research center, and it's a slightly different purpose than purely Old Charity had. I think that's what the mayor and others really see as the opportunity. One thing, though, that Levitt also did want to do, and since you asked about him, is, and frankly, the community, you see this written in our reports, was to move away from the state running the public hospital to having it managed by an experienced hospital operator, and that has actually happened in the last year. So if you dial back to all the things that we were writing and thinking about, some of them didn't happen right away, but they're beginning to unfold. And so I have a great deal of hope, actually, that we're going to finish this story with a really strong health system that I hope is going to continue to be person-centered, be a lot better quality even than it's gotten to be today, and I hope a lot more affordable. That's really the goal.
And how does the Affordable Care Act affect changing healthcare the way you tried to do?
So back to the money, we have a really high rate of uninsured in Louisiana. We have a lot of working poor who are sometimes working a couple of jobs. They're service industry, they're artists, construction, fishermen, uninsured in our community. To get Medicaid in our state, you have to make less than $2,000 a year and have a child. It's $2,000 a year, not a month. That we're at the floor for adults. Now kids are covered really well. And so we have this, we remain with this gap of maybe 300,000 people still in our state who don't have coverage, even with the success of the Affordable Care Act. The state did very well in enrolling people, but so we had a lot of uninsured who were working and were not eligible for employer-sponsored programs, couldn't afford their own, and were not eligible for Medicaid. The Affordable Care Act could still provide coverage and give people an insurance product that's going to allow them to go to the marketplace and make that marketplace compete for them, which is really what I would want to make the service competition and quality competition there. But we're not quite all the way to the coverage that some states have enjoyed, because Louisiana has not expanded Medicaid yet, though there's a lot of community will to do it. What we have in New Orleans is that patch of the waiver, which is giving people access to primary care. So our rate of uninsured in the community has dropped dramatically. It's only about 15% right now, but still that's 15%
But
too
my
many.
question was a broader one, which is we want to move. We like to think New Orleans can be a template, whether it's for its K through 12 education or its community-based primary care services that you did. Will the Affordable Care Act help us as a nation move to a patient-centered, community-based healthcare?
And that's a good question. So let me start by saying, repeating what I said, which is that in the absence of the fee-for-service or other trappings of the typical healthcare system, the very patient-centered care, patient-centered medical home type care grows in the wild. Team-based, integrated mental health, population focus of care. That's what happened to us in the community. Over the course of time, whether people got coverage on new plans on the marketplace or even through this Medicaid type waiver, those are fee-for-service payment models. And it's kind of pushed us back into a transaction-based healthcare system, which has stepped back, really. The model that Kathleen Sebelius loved that we had in our community health in New Orleans was that it was population-focused, value-based reimbursement.
In other words, no fee-for-service.
Right, just
if
where
you took this population, you'd get this much.
That's right, and so it's where the Affordable Care Act wants us to get. We had to just back up a little bit, and now I think the Affordable Care Act is going to catch up.
But isn't that weird that the Affordable Care Act is causing us to back up for where we should be?
It's just our community, because we were ahead. What's happening around the country is that because now we have coverage, we're starting to intensively focus on this piece about value-based payment at HHS and across the country. So in other words, now everyone's got a means to pay, so that doesn't become the primary issue. Let's focus on making sure that they're able to pay for something that's giving them the kind of value that they want, something that's person-centered, something that is not so much about transaction, but really paying for outcomes. And it also allows us to have better data because of health IT, because of our ability to measure quality. We can say it's really about thinking of how well the community's doing, not just whether they're doing lots of stuff to the patient. So we were a little ahead of the Affordable Care Act is what I'm trying to say. But now the Affordable Care Act is catching up, and I see that it's going to help Louisiana do that also.
Now that you're somewhat freed from Louisiana politics, and now that Bobby Jindal's a lame duck and leaving, what have his cuts and his Medicare stance and Medicaid stance and everything else, including his stance on Tulane LSU, how has that affected things?
Well, interestingly, the governor has been really, you're not going to like my answer to this question, but I'm going to answer it this way. The governor's been really supportive of the clinics, in particular the Community Health Network in New Orleans. He recognizes that it's it's a smarter way to spend money. It's getting good outcomes because we have the data to show it, and that it's well liked by the docs and the patients. So the model, very supportive. I think the challenge for us has been this gap of people who don't have coverage, but he's been supportive of continuing that waiver. His administration has to submit it. I think he definitely is supportive of the IT infrastructure. That's something that's gone on all across the state since he's been in governor. I think the priority thing where I would like to see that the state spending a lot more emphasis has been in public health, where they've done a pretty good job. But the reason I bring that up is because the governor and his team know that we want a healthier state because that's a better workforce, that's a more vital population, and it's a place you want to live. But to get there, healthcare is only going to do so much. We're going to have to make sure that we have the right kind of environment where people have the chance to make a healthy choice. It's the easy choice. And that and his investments in public health have been pretty good, but I think advancing that even further would be exciting to a lot of people down there to see that we really get beyond thinking about healthcare as the solution, but really more broadly about all the inputs to health, including public health and the social determinants.
A few minutes ago, you mentioned that we moved from a charity system hospital that was focused really on indigent care, and now have a university medical center that's doing different things, I think you said, including research and biomedical studies, as well as also doing indigent care. For a long time in this country, the major medical research and some of the major hospital care has been delegated to the academy, to universities, to University of Miami or Harvard, or with a whole hospital system in Boston. And now in New Orleans, you have that, and sort of with a clash between Tulane and LSU that can't quite ever get their acts together. I speak as, well, somebody's had to listen to far too many discussions of this. Is this really the proper way to have saddled our research universities with this thing that is now a real albatross financially? Or is there a better way to do our hospitals and connecting them to great research universities?
Well, first of all, it's not unusual for academic health centers to compete, right? I mean, you could go to any place in this country, any town, especially something as small as New Orleans, and they'll compete. Now, I'm married to an LSU guy. So we have an inter-school marriage. It's gone very well. It's 20 years along.
Yeah. I hope you don't speak about hospital systems at night.
We do just fine. But look here, so the competition is normal and it could be healthy, except that we're a pretty small state. And so cooperation is what we had hoped. I mean, if you want to go back to things that we were planning for and hoping for, we, the grassroots folks, it was that there would be more integration of the two sites. But it's hard. It's a long-standing rivalry that is going to be hard to overcome. You're kind of touching on a question that I think is the reason I left academics. So I'm going to make a tiny leap, and that is to say there's a lot of burden on the healthcare system to be all things to everyone. Lead research, build the economy, make people healthy, and we think now about health as being healthcare. We think that antibiotics and catheterizations and dialysis and all these fantastic new drugs and devices that we have are the solution to getting us healthy. But Donna Shalala said it well on the panel today. The things that really extended life expectancy are actually public health things. I'm paraphrasing you, but it's vaccinations, it's hygiene, it's housing policy. Those were brought to us through a related but distinct field of public health, which used to be a much better partner to medicine in the way that I think academics was not so dependent on running healthcare. It was really developing new science. So there's been a lot of merger, and I think that's put a lot of pressure on the healthcare system, especially a healthcare system that's still got a sickness model. It's still not, its business model is not predicated on keeping communities well. And it's also, by the way, the healthcare system is not accountable to everyone in the community. We'll step in public health, which is really making a resurgence. If you look at Ebola, what made the huge dent in West Africa, first of all, the crisis there was a lack of infrastructure, public health infrastructure, not even medical. What made the big dent was when we stepped in and assisted with basic hygiene, hand washing, sanitation. That's when we really started to see precipitous drops. So some of those really basic public health practices make a huge difference, not just globally, but in the US. And what we're seeing in places like New Orleans and around the country is that the more public health steps up to the plate, and sometimes is at the head, the better communities do, because public health is accountable to everyone in a community. It can partner with medicine and business and the faith-based community and neighborhood associations and be a backbone to bring everyone to the table. It's not typically a business model that's predicated on people being sick. It's just the opposite.
Yeah, and that may be a problem with schools of public health. I mean, Tulane has a school of public health. Harvard has a school of public health. They're both younger, lesser siblings to the medical schools at such institutions. Partly, I assume, because medical schools get a lot of money, but if you graduate from a school of public health, you may not, it may not have as much funding. How do we change that?
Well, they're called the two siren sisters, Panacea and Hygeia. So medicine is Panacea and public health Hygeia. And
these are Greek gods.
That's right.
Yes.
And the Hygeia is the lesser, less sexy sister that people don't tend to fund as much. And someone said it that medicine. Someone said it earlier today, I believe, but it's a pretty known statistic that about 97% of our spend in the U.S. is on health care. But healthcare is only about 10% of your health outcomes. Public health gets about 3% of the spend. There are other things that affect outcomes. So we're investing a lot in a part of the system that isn't going to get us as much return on investment. So shifting that is going to require a few things. One is for us to do some transformation of public health, just like we're talking about transforming healthcare. Value-based, changing the way we pay for it, changing the information model, seeing that it's much more person-centered. We're going to have to do some similar things to public health. We did this in New Orleans. When Mitch asked me Mayor Landrieu asked me to be his health commissioner, I went in to do it so I could transform that health department. It was recognized as the worst in the country. We used the accreditation model to rebuild it. We deconstructed it, and we rebuilt it on the blueprint of what's called an accreditation process, which is basic, good business functionality, quality improvement, workforce development, an improvement plan, a strategic plan, really the foundational things that you would want from any institution, especially one that's being funded by taxpayer dollars. And it is now, by the way, accredited. It's one of the few in the country that's in the top of its class, and it's able to lead in the community. That is happening in other places in this nation, and it's necessary because public health over the course of all this time has gotten more and more marginalized. It takes care of marginalized populations, the poor, those with diseases that no one else wants to touch. It's underfunded, it's got siloed funding, and so it cannot be a strong partner to medicine or to any other part of the community right now, and it really needs to get fixed. It wants to fix itself, and so that it can take its rightful place in the community to do the things that we need to do to advance life expectancy and improve health for this country.
You were a dean at Tulane School of Medicine before you joined the Landrieu administration. Did you ever pay much attention to the School of Public Health? Would you have liked to merge the two?
Yes and yes.
Okay.
And I was actually, I was on faculty at the School of Public Health.
Okay.
And
I didn't know that.
That's okay. Because I was mostly affiliated with the School of Medicine. I began working in public health when I was in college. I worked my way through college at the Massachusetts Department of Public Health. Had a great experience there. went on to study it and was doing research, though, in public health. And I had been migrating myself away from medicine. Some of these things in my head, medicine was rigid and hard, and you couldn't really tackle health because you didn't have all the tools. And once people left your door, they were going out into the world, and it was very hard to help them, especially back in the 90s, or the 90s, listen to me, the early 2000s, that we didn't have ACOs and the kinds of models that we're trying now that reach into community. And I wanted it to be more engaged in public health. When Katrina happened, clearly everything changed. Everyone had to put down their pencils and figure out how they were going to help, and that's exactly what happened. But
And you were at Tulane
I was at
then?
Tulane School of Medicine then, and when we through the School of Medicine, Scott Cowan, who was the president then, I know you know Scott, really was empowering and said, make a difference in the community, do whatever you need to do. So we built all that through the School of Medicine, the policy work and the clinics that we did in partnership with others. But I remained in the School of Public Health. The merging was something we talked about then, but I have to say, I didn't understand it as well. And the reason I was sort of smiling is I have to tell you that the real truth is that I was a complete snob about public health. Yeah. When the mayor asked me to co-chair his transition team, I said, sure, all of us community usual suspects in health were like, yeah, we need a better health department. It's really broken. It can't advance health. It's an important part of the puzzle. And I was trying to help him find somebody to do it. And I was sort of figuring out what it would look like in the future, and we were interviewing candidates, and the woman that we offered a job to, she turned it down. And I remember very well, I was driving back from Baton Rouge for something, and I was on the phone with the mayor's chief of staff, and she said, well, so-and-so turned down the job. And I was so relieved. And I realized in that minute that I was relieved because that was my job. Like
yes.
I had been.
Well, thank you for your service.
Sure, and I just fell in love with it. I mean, but when I went down the street to it, and it was like I saw the world in a completely different way than I had seen it. It was 2 blocks that I had been at the academic institution. I'd been on the street, Walter, like literally on the street after Katrina, building stuff, being with community. But you don't see community in the same way until you are accountable to them as you are when you're a public servant or when you're, especially, I think, a health commissioner.
Have you kept your residence there in case we have to run you for mayor?
Yeah, no. I have kept my residence in Louisiana. I'm in Jefferson Parish, so, yes.
Donna, your name has been, Secretary Shalala's name has been invoked 5 times, I think, in this conversation.
You should have sat in the
I
back.
want to ask you either to ask a question or say something, but also maybe even address the public health, the academy issue, because you ran 2 universities and a college, if I remember correctly, and just anything else you may want to say.
There's a complicated relationship between academic health centers and public health. As you know, at the University of Miami, we were the doctors for Jackson Memorial Hospital, one of the great public hospitals in the country. I have a different question for Karen, though. The population changed in New Orleans. Mm-hmm. Were you thinking of building a health system for the previous population? Because it must be down about 20% at least. And did that population, did everybody, who came back to New Orleans, and how did that affect your strategy for the community?
We were, the expression I use a lot is that we jumped off the cliff and we were building our wings on the way down. It was the most free fall experience that I would never want anyone to go through, but we did our best to try to figure out what was coming in the next few months. We didn't have the luxury of a lot of time, but we did a lot of predictive work. So for example, we used the post office and the power company to look at power restoration and return and mail that was getting delivered again. The state had the clever idea to do that and try to figure out which parts of the city were coming back and use that to guesstimate which parts of our population were returning, because we just didn't have any other good sense data. The Kaiser Family Foundation was on the ground really early and did some door-to-door survey work for us to help us think about what diseases were coming back. But I think what really helped us, a couple of things helped us, maybe 3, I'll pick 3. One, when your town falls apart like that, when the people who choose to come back are innovators. So it was a lot of people who were really willing to work on the fly and didn't have to have a lot of static rules and expectations. That meant we could do sort of a continuous improvement every day. So every day we would look back at who came in today, what do the books look like tomorrow, based on the data that we were accumulating, and try to sort out how we were going to have to staff up and what our pharmacy needed to look like, everything. We were working this all the time. It also, I think that the last thing that helped us in this time was we had flexible funding. The way we were paid in this population capitation, this population payment, was based on the number of folks that we had in a look back, and we just estimated going forward that we'd have about that many people. And the reason that gave us a lot of bandwidth is because as a clinic manager, so I was running a few clinics at the time myself, plus we were doing the policy work, but in my clinics I could say, well, I know for 6 months I've got this much money. I think this is the population. We'll nuance this literally every week until we get the team structure right. And because I had multiple sites, we could move the teams around. So I'll give you a specific example of that. We had a clinic in the Treme neighborhood. This is the one that was at Covenant House. It's now at the old Ruth's Chris. Then we had this one in New Orleans East with the Vietnamese American community. And the Vietnamese American one started after this first one. So we modeled it. We started the staffing out in the East in the same way, including integrated mental health. But as we went through the first few weeks of that clinic in the East and looked at the data of who was coming in, people weren't taking up mental health services. So we had to find a new model. We worked through the staffing on that till we found a place that a duly boarded med psych doctor was, because they would go in the room to medicine, but they wouldn't go in the room to mental health services. We didn't need social work because the Community Development Corporation just next door that was our partner had all that. So we were able to finesse the patient-centered medical home model on a really iterative, ongoing basis based upon the population literally in that neighborhood who was using the service. What's happened now 10 years hence is that we are, they're gonna know the numbers, the New Orleans folks. It's a little more than 80% are back. We grew in the suburbs. People moved out of the core of the city, and so there were parts of the city still down, but what's changed is we have more of a Latino population. And we did not, of all the challenges, we could overcome mental health and physical health and the funding and everything, but we had a lot of language challenges. So we had to start translation programs, language access programs. We had to teach ourselves how to do it because we'd never had to practice medicine that way, and have come quite a long way. We've sort of tripled the size of that population. So there were new challenges, but a lot of the same folks have now come home. And I love that about our city, is that when people felt like it was safe and it was time, they came back home.
Further questions? Is that Phyllis back there? Hi. Speaking of New Orleans. Yeah, go ahead.
So, hi, Karen.
Hi.
Thank you. When I was with the Kaiser Family Foundation and traveled after Katrina and interviewed a bunch of people, the only word that comes to mind is they were so unmoored from their healthcare system. They didn't know where their doctors were, how to reach them, if they would come back to the city. They didn't know where their health records were, if they still existed. They couldn't even get a prescription filled. So I'm wondering, as impressive as the neighborhood clinics sound, and they truly do, congratulations on that, is there a plan in place that if there is another Katrina, to keep these people connected to their healthcare system in ways that they weren't after Katrina?
And let me add, can technology help us do that?
Yes. We've been tested, actually, and we can talk about, and so I'll talk about that a little bit. Unmoored is right. As a person who, I still practice, but I was practicing more then, I didn't know where my patients had gone. I didn't know which of them had a pull out of I didn't have a registry. Who's on Coumadin? Who's on a blood thinner? We didn't know chemo regimens. It was. I've used this word before. It was terrifying at times to know that you had responsibility for patients and you couldn't find them. And the VA was a great exception. So as a contrast, they were able to identify people because of their technology underpinnings and some of the other systems like Ochsner in the community. What we have built in these neighborhood-based clinics, which are part of a growing fabric of our city, and I talk about them a lot because they're grassroots, they're brand new for us. They've created a model of care that's stuck and is financially viable now. They're also the most IT advanced in the community. So these clinics they're not metal folding chairs. These are really sophisticated patient-centered medical homes, NCQA recognized. They're on an information exchange. Someone shows up in the ER, there's an alert notification given to the practice to know about that. They have extenders through community health workers. These are really sophisticated sites of care that have pushed the rest of the community to adopt electronic health records because of competition. If you look at the payer mix of these clinics, they're attracting Medicare and private payers because of the kinds of service that they deliver. We were tested a couple of times with people being displaced for care. The one thing what will fall apart is financing. If the people who are on the waiver, the 56,000, for example, have to leave the New Orleans area to receive care because the city floods or something happened, they will not have coverage somewhere else. So they will be immediately uninsured. And that is just a frailty that we haven't been able to fix. But their data is web-based, and they have portals, and they have access to the information, and so will the clinicians outside of the setting. We have protocols in place. The clinics are part now of the recovery and response infrastructure. They go to the emergency operating center, one of their representatives at City Hall, and are a part of the planning, the response, and the recovery. None of it's perfect, but what I'm saying is there's been a lot of deliberate action, whether you're uninsured or insured, to make sure that you're accounted for. I have to say, I think the insured are less a part of that fabric. So if you go to a regular private practice in the city, you're not really an integrated part of the system yet.
Is that because we don't have electronic medical records for private practices as well as you do for your clinics?
I think that's part of it. It's also because the clinics are so organized. They're a unified voice. It's something that we worked on really hard, was to make sure we had a voice at the tables. And private practice in New Orleans is either part of big systems or it's still private practice, and the physicians there were not organized in that kind of a way, I think, yet. So it's a gap that we have to fill. But I just want to say something about technology. I want to be able to squeeze it in. It's a non sequitur a little bit, but I'm so proud of the stuff that we've done. Like this is our little engine that could, our little three-legged dog city that stood up on its knees. And so in addition to the EHRs, we've been using, we piloted a thing with CMS and ASPR, the Assistant Secretary for Preparedness and Response. When I was health commissioner, we had Isaac. This is another test that we had. And the power was out for about 5 days consistently, some parts of the city longer. It rained for 72 hours. The thing was over us. It wouldn't stop. Nobody would evacuate. Nobody we had on a special needs registry wanted to go, right? And especially the seniors. So when the power had been out for a few days, it was clear that there were people trapped in high rises that needed help. This is Hurricane Sandy, same story, happened up there. And you're in the emergency operating center, and you know that there are people in need, but you don't know how to direct the power company which parts of the city to turn on first. We have a priority list. It's hospitals and dialysis, et cetera. But then you start to get down to, is it gust high rise, or which one is it that goes on? And so we went door to door because we couldn't figure it out. But now we worked with the feds, and we piloted a system using Medicare data that can be pulled down in emergency, light up a map of who lives where that's on oxygen. For example, we did oxygen dependency for electricity. We did a test run in the community. We pulled down the names of 611 people. We went door to door for a couple hundred of them to see if it was really that person, if they were on oxygen, with really good accuracy. Like you knock on the door and you say, "Hi, I'm from the government and I'm here to help," and people actually open their door, which is really nice, and they don't slam the door in your face. Only one person did, and it helps to show up with the fire department, I will say, if you're ever going to do something like that, because people love the firemen, and even if they don't care about the health department. So the point is that we piloted a system that was now able to automatically tell us who the most vulnerable in our community and how to find them, which has now gone to scale. It is now happening nationwide. We just released earlier this week from HHS a web place and a resource for every community in the country that they can go to if they need to know the most vulnerable in their community based upon the Medicare database, whether they're on oxygen or they're electricity dependent or they have mobility issues. So there are a lot of technology ways that we can leverage public health and medicine together to help people when they're most in need, whether in disaster or every day.
Hi, my name's Tim Woodward. I was a public health service doctor in Louisiana for a number of years, having worked through Tulane, and it's fantastic. And I'd actually gone to New Orleans year post Katrina, and to hear what's happened, what you're going to do now is It's fantastic. But my concern is, I actually worked at Little Charity, which is Huey P. Long, which is outside. And it seems as you get further, it's like radiation, the energy decreases the further out you get. And just recently, literally this year, they closed Huey P. Long, which is, and I bring it up in this context because pre-Katrina, it was all connected as the charity system.
Is that in Jefferson Parish or where?
That's in Rapides Parish.
Rapides, so way upstate.
Yeah, it's right into the mid portion of the state. And as a charity hospital, one of the strengths as the system is that whatever happened to one, you could at least hope to get some feedback and fallback. Now with the closure of the hospital, unlike what you've had in terms of some infrastructure, there was no infrastructure prepared for that. And I'm just wondering, are you going to try to implement those ideas that you have there across the state? And the second point is also, because I keep in touch through some public policy people I know, how are you going to fund? I know you alluded to non-government or non-state-run monies, but particularly once you get out of New Orleans, it's really going to be kind of interesting to see how you do that.
One of the reasons that people were so concerned about closing big charity is that was a lot of what Levitt and his team were trying to get us to think about and not rebuild the beds, was because of the reverberations across the state. So it's one of 9 hospitals across the state, and they're all connected, as you say, in some way. And one of them had been kind of privatized in Shreveport, but the rest were a part of this this infrastructure. The census dwindling in many of them. I don't know, you might agree, or I don't know when you were there. I mean, big charity, I'll give you an example. When I was a third-year medical student in, I don't know, 90 or 91. I'm getting old. I can't remember all these details now.
You don't have to tell.
Well, that's okay. The age part doesn't matter. It's public knowledge, but I just can't remember the year. I delivered 22 babies at Charity Hospital in the month that I was on OBGYN. Within about 3 years, they had so few deliveries at Charity Hospital, they could barely keep the accreditation program, because once we started paying for deliveries at the rate the private sector was paying through the Medicaid and other programs, women started to go to other hospitals in town like Baptist and Truro. And so when people got coverage, they were leaving the system because the system was built around doctors. It's just the truth. We built it around our schedules, around the academic schedule. Clinic was open when we were in town. If there was a conference, clinic was closed. If the person didn't know and they took the 2 or 3 buses to get there and took off work, and the clinic was closed, it might be a whole year till they got back in. And so if they got coverage and had an option, they were voting with their feet. I mean, that's just the data shows that, and that was certainly my experience of working there for a lot of years, National Health Service Corps, and as an administrator. I mean, I love the place, but we were not patient-centered in the way that we needed to be. And I think in the smaller towns, it was less the case. I think they were more a part of the community fabric, but as you say, they got caught up in some of the other challenges and the funding challenges. No opportunity to reinvest in the capital infrastructure, and they couldn't compete with the private sector. So it's happening. You're right, and it's something that the governor has made as an agenda, is to make sure that he privatizes those hospitals and works with the private sector on what's the best thing to do with the bed. I think at the end of the day, here's what I would say. What you would want for your family is, or for your patients, is for them to get the best quality care that was most patient-centered that it could be. And wherever that would be physically is where you would want them to go, or not go, as Eric would say, as the case may be. So, and I'm with Eric on that, by the way. More convenient, more accessible, and more person-centered. So I think the hard questions that we've all had to ask ourselves is it about our nostalgia and love of bricks and mortar, or is it about our love of the people that we're here to serve? And that's going to be sort of the trade-off as we go forward.
Further questions? If not, I'll end with a couple of quick ones, real quick. New Orleans is an example of this, but I mean it more as a national question, which is consolidation of hospital systems into major hospital corporations. I think in New Orleans, there's HCA, Ochsner's trying to grow, and Children's Toro. Probably one too many conglomerates for a city our size. But with the Affordable Care Act, do you see independent hospitals all becoming part of a system? And if so, will that system be vertically integrated, so it'll do everything from coverage, to community?
We are seeing across the country, more consolidation in health systems, you're right. We're also seeing that for a variety of reasons, physicians are employed, sometimes by choice. Younger physicians tend to not want to hang up their own shingle.
In other words, employed on salary
On
by
salary by a
hospital
big health system.
corporation.
I think this is something that we're paying a lot of attention to, speaking now from the federal level, because we want to make sure that there's sufficient competition, that it allows for competition on things like service and quality, but also on price. And that this is just a place we're going to have to be really thoughtful as we advance payment reform, that, you know, the bigger systems are going to be more competitive in new payment models based on value and population health, because they'll be able to integrate across the continuum, have all the way from home health and beyond, community health workers, to even more upstream services. And because they'll be able to manage the data. They'll have the data platforms to be able to do the analytics. They'll be able to get into things like precision medicine. So I think all that is unfolding. We're watching it, and we're encouraging the outcomes piece, but not so much the consolidation. I'll tell you where we're really paying a lot of attention, Walter, and I'll go back to, you know, places like Rapides Parish or other small communities, is that those, we don't want, the policy goal is that no one gets left behind, and this is where we have to really be thoughtful. Models of value-based payment using health IT, that works sometimes, even in rural communities, but we have to make sure that we don't go so fast that the people in those communities get left behind, because their institutions get left behind and they don't have access to care before technology can catch up and help them in new ways. So it's going to be a really fine dance, and it's just something we'll all have to pay a lot of attention to so that people don't get left out.
Well, that actually incorporated what I was going to ask next, so I'll say thank you. And there are a lot of lessons coming out of it, and the main one being resilience.
Yes.
Who would have thought, you know, and resilience is a hard trait to understand, but you saw it in Sandy, you saw it in the schools, but part of the resilience, as you've described, is not just building back what was before, but using it as the opportunity to build it in a new way.
That's right.
Thank you.
Thank you very much.